everyone, my name is Salia Farrokh, and I'm a neuro-ICU clinical pharmacist and excited to talk about this case today. Here's the agenda for our meeting today. Starting with the bottom line up front, I recommend to optimize orthopedic surgical workflow by pulling 4 CRNAs instead of 2 track designated anesthesiologists, pulling 2 PAs in addition to 2 track designated surgeons, assigning patients with low BMI to track A and assigning patients with high BMI to track B, reducing interval time in low BMI to 80 minutes, and reducing interval time in high BMI to 86 minutes. This will result in 47% increase in cases in track A and 44% increase of cases in track B. This will also result in 30% decrease of flow time in track A and 25% decrease of flow time in track B. These changes will result in a better patient experience, resource utilization, and financial performance. The objectives are to increase surgical cases per day and to reduce patient flow time. Looking at the current workflow, patients need to get registered first, then undergo sedation, and then surgery, which takes on average about 100.7 minutes, and then the rooms need to get cleaned up. This is a job shop process where patients have a pre-specified workflow, but may have different needs based on patient characteristics. The most described evidence is BMI, which those with a higher BMI need a longer surgical time. Let's look at our base case right now. As of now in our institution, every track does about 4 surgeries per day, and on average, the patient workflow time is about 200 minutes. Anesthesiologists are unfortunately overutilized, up to 97%, and the surgeons are utilized at about 78%, which is also concerning. But the most important piece and concern to me is that, as you can see, because we don't have enough staff, you can't have surgeries and sedation happening at the same time. As you can see in this animation, surgery is happening and almost done, and there is no one in sedation in the same track. That's because simply we don't have enough people. Your surgeon and your anesthesiologist are in the same room operating, and the other room is staying empty simply because we don't have enough staff to take care of that space and utilize that space. There are other concerns with our current model. Number one, we know that there are more surgeries happening in the US every year, which can put our surgeons and our anesthesiologists with this model at higher rate of burnout, and patient dissatisfaction could be a problem. And also there is financial factors. If our surgery teams are not staying in our institution and retention is a concern, that could be a huge financial burden. And lack of standardization can lead to waste and higher costs. Let's look at 4 lenses now. Let's start with utilization. Does utilization matter? It does. In fact, by doing the utilization alone, our model can improve significantly. As you can see here, the only difference from this case to the base case is that we've hired 2 additional anesthesiologists, so 4 anesthesiologists in total. And in addition to the 2 surgeons, we have hired 2 PAs, so 4 folks that are helping with the surgery procedures. And this has resulted in a much better utilization for both anesthesia and surgery team, as you can see. And with this model, we can do up to 6 surgeries per track. And also the average flow time is about 140 minutes. For the sake of showcase, I'm not going to talk about a statistical analysis or the confidence intervals here, but I will talk about them for the proposed model that I would like to implement. Let's look at the next lens. And that's about pulling. Does pulling matter? As you can see, pulling probably doesn't help us much. The number of surgeries remain the same, the flow time remains the same, and CRNAs or anesthesiologists are still overworked, and there is a bottleneck there. So this is a huge, I think, message to our administration that unless we hire more people, pulling will not help us. So pulling may help us, but we do need more staff to support that. Next, let's look at variance. As you can see, now I have designated track A to low BMI and track B to high BMI, and this is the only change. We have improved track A, meaning maybe we can get 5 surgeries instead of 4, and the flow time is better in track A versus track B, but our CRNAs are still overutilized, again, emphasizing that this might help, but we need more staff to support this system. But there is maybe some utility to designating different tracks to different BMIs and maybe different surgeons and anesthesiologists with different skills. What about psychology? Can we schedule our patients a little bit more far apart so that when they come in, they don't need to wait a lot? So maybe that can help with the flow time, but not so much for the number of surgeries. And also CRNAs are still utilized very much at 95 to 97%. So that might not be the best solution in my opinion. Now I would like to talk about my solution for a Hipkins hospital. Based on the 4 lenses analysis and the primary literature, I recommend that we only hire or utilize the CRNAs that are already hired in a pool model. So we have 4 CRNAs total, no designated anesthesiologist per track. I would like us to keep a surgeon for each track, but also hire 2 PAs in a pool model. I also advise that we designate track A for low BMI and designate track B for high BMI. And because of the improvement in workflow and efficiency, I would like to propose to schedule patients in the low track BMI at 80-minute interval times and the high BMI track to 86-minute interval times. I would like to back up my recommendation with a primary literature that showed in Europe when anesthesiologists had a dedicated room for preparing patients, meaning giving them sedation and intubating them, and then sending them to the operating room for operations, they were able to reduce surgery time and improve flow time. As you can see based on the model and the animation that is shown here, because you have more staff, you can have sedation in one room and surgery in the other room simultaneously, and this can definitely make our system more efficient. Now I would like to highlight the statistical analysis. As you can see, the number of cases are increased to an average 6.6 for track A with the new model, with the confidence interval of 6.1 to 7.2, and for track B up to 6.2 on average with a confidence interval of 5.7 to 6.6. Using the t-test, that was statistically significant from the base model. And the average flow time was improved to 1.43 on average for track A and 1.48 in track B, and that was also statistically significant. Looking at the main objectives, we have accomplished a higher rate of cases, 47% increase in track A and 44% increase in track B, and also a reduction of 30% in flow time in track A and 25% in track B. And there are other improvements that you can see in this table. Optimization was done for the sake of completeness. As you can see, similar results. However, this model is advocating for hiring a higher number of surgeons and dedicating anesthesiologists to one track despite pulling some CRNAs. Overall, I'm not sure that this is creating a better model than the one that I proposed, so I would like to stick with the model that I have. Going back to the lean model, I would like to highlight the importance of standardization of our workflow by designating different BMI tracks. I also would like to advocate to have a visual dashboard, not only in the OR, but also in the waiting room for patients to know when their surgeries may occur. And also by utilization of more CRNAs or anesthesiologists, they can be freed up to go into the waiting room and updating the patients as they're getting them ready for the surgeries. What about the SWOT analysis? The strength is that this model was able to accomplish the objective KPIs that we had in mind. The weakness is that there might be some additional costs initially, and that I was not able to include trainees or fellows in this model or an on-call team for emergencies. There are opportunities to implement robotics for high BMI surgeries in the future. And also the threat is that if there is a budget cut, this may not go live, or there might be competition from other institutions with similar models. In conclusion, by utilizing the model that I propose and the primary literature search, we should change our model to 4 pooled CRNAs, 1 designated surgeon per track, and 2 pooled PAs. Patients with low BMI should be regrouped in track A, and patients with high BMI should be regrouped in track B. Interval time should be changed to 80 and 86 minutes in track A and track B respectively. The changes will increase number of cases by 47% in track A and 44% in track B, and they can also reduce flow time by 30% in track A and 25% in track B. Decreased surgeon and anesthesia utilization will provide better well-being for them and hopefully retention and efficiency. In addition to improvement in the KPIs that we talked about, cost savings are expected by utilization of a pooled cRNA model as well as allocating patients to different BMI groups. Thank you so much for your time and looking forward to your feedback.